Weir. I'm an adult pulmonologist, and I work at the National Heart, Lung, and Blood Institute in collaboration with Inova's Advanced Lung Disease Program. And I'd like to thank the Asthma and Allergy Foundation for inviting me today to talk to you about the history and future of asthma treatments. Hopefully we'll talk about some of the myths and dispel them in current asthma care, and more interestingly, present some of the future treatments. So, to begin with, I'd like to divulge that I have no financial disclosures. So the topic of asthma treatments is really very large, and I just want to make sure I was very concise and precise about what I will be discussing today. We're going to talk about the mechanism of disease, because that's very important to understand why we choose certain treatments over others. We're going to briefly talk about how directed therapy is given today, because my colleague is going to actually speak about this very nicely after me. We're going to also discuss some of the newer pathways of disease that have only recently been discovered, so we can share some of the more exciting, future promising therapies. So to go forward, sometimes you need to go back, and the history of asthma is a great example of how the mechanism of disease is actually crucial to the proper treatment of this disorder. This is a photograph from the Burns Archive showing gas inhalation in 1855, and they used to believe that this was actually a treatment for asthma and other conditions. So, here we go. Asthma has been described even in very ancient civilizations, and the symptoms are so nonspecific, as you're all very well aware. It wasn't until the 16th century that the Belgian physician Jean-Baptiste van Helmont properly attributed asthma to the pipes of the lungs. He actually described asthma conditions very well, but unfortunately it still was felt to be very rare up until the early 1900s. In fact, it was felt to be somewhat psychosomatic, especially when it affected women, which I'm sure you've heard before. Mm-hmm. It wasn't until the mid-1900s, though, that really the role of inflammation in asthma became more appreciated, and that's when asthma treatments truly developed. Up until then, fumes and herbs were used, sometimes making the condition worse, and some of these herbs, interestingly, did have mild bronchodilatory properties, and the first meter dose inhaler was actually an atomizer that was designed for perfume administration, so people were starting to catch on. So therapies prior to anti-inflammatories took on the medicinal flavor of the times, and I thought asthma cigarettes were probably the biggest oxymoron I'd ever heard of. So although many unusual treatments were tried, some were actually effective. So ephedrine was used by the ancient Chinese, and we know today it does have bronchodilatory properties. Epinephrine and isoproterenol were available in the mid-1900s. But it wasn't until the early 1900s that adrenaline was isolated from animals, the glands of animals, and it was administered with good effect. And this is very important because this is the backbone upon which we developed the inflammatory pathways that have become better understood in the later 1900s. This leads to some of the therapies that we use. The first use of corticosteroids was actually in the 1940s. And it wasn't until the 1970s that we had the first inhaled corticosteroids developed. And beclomethasone was the first inhaled steroid to be marketed in what's now a sea of effective inhaled therapies. So beginning with the 1980s, what happens is scientific technology gets better. So we start to understand what the cascade of inflammation looks like, and that's when asthma therapies really take off. So now today, because of the work of these fine physicians and scientists, we know that asthma is an inflammatory disease. It involves a specific pathway of inflammation, namely that of the helper T cell type 2 lymphocytes. And there's significant overlap between this pathway and the pathway of allergic diseases. Specifically, immunoglobulin E tends to be very involved in asthma and allergies, and so it's a common target of many of our therapies. So are mast cells for another pathway. But you know, there's a variety of different pathways of inflammation that have been discovered since then. We know that atopic asthmatics have an eosinophilic tendency. We know that there's a neutrophilic inflammation in smokers and what we call sudden asphyxiant asthma. These are people with very severe bronchial hyperresponsiveness. There's even a posse-immune subtype that's been recognized, and that means asthma without the absence of detectable inflammation. So whether it's episodic or chronic unremitting, severe or mild, asthma always involves some degree of bronchial hyperresponsiveness, usually due to smooth muscle contraction, excessive mucus production due to hypertrophied glands, and in some, even airway remodeling. So this is a cartoon that I like to draw for my patients. And I show them this because it explains why it's so hard to breathe. When you have different lymphocytes and mediators unleashed, you've got this cascade that causes inflammation in the lining of the pipes. And so you can imagine that with this increased airway resistance, it's difficult to breathe. You've got tighter pipes. And as if that wasn't hard enough, now you have mucus plugging those already tightened airways. So this is very important to understand because that explains how they feel. And unfortunately, this can be triggered by a variety of different exposures. This is a closer look at where the swelling or inflammation is occurring. You can see the already hypertrophied or thickened smooth muscle lie around the edematous submucosa. So today we can break down the treatment of asthma by age and severity. This talk only really addresses patients over the age of 12. But severity is also based on how frequently an asthmatic needs to use their rescue inhalers. It also has to do with the spirometry, or more specifically, how forcefully they can blow in 1 second, the FEV1. Their history of hospitalizations and intubations also goes into this calculation. And the reason why it's important to figure out how severe they are isn't just because of the prognosis, but we also need to weigh the side effects of these medications against how sick the asthmatic is. The side effects of our medications are sometimes mild and treatable, but some of the side effects are so severe that they actually increase your morbidity and mortality in and of themselves. So the current standard of care in the United States today is depicted in this diagram, which I've stolen from the NHLBI's National Asthma Education and Prevention Program. It's a report from 2007, and it's called the Expert Panel Report number 3. I always want to call it a review. It's a report. The slide shows you how to classify the severity of disease based on frequency of symptoms. Now, once you change your medications, you actually need to reassess every 2 to 6 weeks. This is another diagram from EPR3, and it actually describes the actual therapy given based on severity or step. You'll notice that rescue medication, or albuterol, which is a short-acting bronchodilator, is only allowed as solo therapy in mild, intermittent patients. Everybody else gets an inhaled corticosteroid. So as the symptoms worsen or the severity increases, the addition of either long-acting beta agonists or leukotriene receptor agonists, as you can see, can be considered. The dose of inhaled steroids can be escalated, but based on what we know as of today, you're supposed to add on these adjuvant therapies first before you increase the inhaled steroid dose. It's not until the patient has persistent symptoms despite escalation of all of these that you consider something like omalizumab, which is an anti-IgE medication. So throughout all of this, it's very nice to talk about the medications, but some of the more obvious stuff sometimes gets lost, and that's what I want to emphasize. Educate your asthmatics, teach them about their disease. Please make sure secondhand and firsthand smoking is addressed. It's just avoidable. Make sure they're taught how to properly use their inhalers. Even the most educated patients sometimes really don't know how to use their inhalers properly. And finally, ask them if they're using their medications. You would be surprised how many of them are actually not. So we've talked about the medications in EPR3. What we haven't talked about are a lot of other medications that you may have heard about. The reason why we haven't discussed them is that, unfortunately, there's a long list of unsuccessful interventions that have been tried, and although I could spend an hour talking about each of these individual studies, I'm not going to. But I will review a few. Anti-tumor necrosis factors like etanercept or infliximab, drugs typically used in rheumatoid arthritis. Routine use of proton pump inhibitors, something we did commonly. Drugs like esomeprazole, like Protonix, to use a trade name. And macrolide antibiotics and statins, which have had a lot of press recently. These have all been recently tested and they've had negative results. These drugs listed in yellow did not improve asthma symptoms or markers. But what has changed is the way we think about the drugs that I did talk to you about in EPR3. So there's an ongoing heated controversy about the safety of long-acting beta agonists. You're all somewhat aware of that. I know my patients are. They ask me all the time. So the original set of drugs that were in this classification were associated with some very severe outcomes back in the late 70s or early 80s. But we felt that these newer class of long-acting, or LABAs we call them, were safer. All that said, they are still on the market and they are still being used. The single take-home message for you and your patients is never use these without inhaled steroids. Anticholinergic therapy, which really in the past we didn't think had a strong role. There were studies of short-acting anticholinergic therapies in asthmatics, and they were always showing no benefit. Well, when the long-acting anticholinergic therapy, namely tiotropium, it's the only one, was approved for COPD, some practitioners began using this. Well, they were sort of using it off-label up until last year. Last year, the NHLBI sponsored trial of tiotropium in mild, uncontrolled asthmatics was published in the New England Journal of Medicine, and the addition of tiotropium was equivalent to the addition of a long-acting beta agonist. So this was kind of pivotal. It was actually superior to the doubling of inhaled steroids as well. So leukotriene receptor antagonists have also been viewed as an adjunctive therapy, and they've been used as early as step 2. Just last month, a study was published in the New England Journal of Medicine suggesting that first-line therapy, meaning this is the first drug that you give them instead of an inhaled steroid, was equivalent to inhaled steroids. Unfortunately, this was not true long-term, it was only true short-term. This study was neat in that they have a different design. They also added the leukotriene receptor as the first add-on instead of a long-acting beta agonist. And the leukotriene receptor antagonist can be either zafirlukast or montelukast, by the way. They found that the addition of these LTRAs was equivalent to a long-acting beta agonist. Again, short-term, not long-term. The reason why this is important is that we've almost been dogmatic in acting long-acting beta agonists for so long. So I think now we're having some other choices, especially even for primary therapy. Finally, there are some newer combination inhalers and some newer inhaled steroids over the last decade, and I'm just going to mention that, but not go into it in more detail. So, now that we've discussed the current management of asthma therapy, we can turn to the future treatment of asthma therapy. The first point I want to make is that up until now, we've treated all asthmatics the same way. We targeted the same inflammatory pathway with the same medications, more or less, but does one size truly fit all? Well, one size doesn't fit all. What about the patients who don't respond to inhaled steroids? We know they're out there. What about the patients who have subtle clinical differences? And what about finding newer pathways of anti-inflammatories? How about targeting something other than the old corticosteroid receptor or the IgEs? Well, with that said, will the addition of a personalized asthma treatment, though, will it make it more confusing? We already know there's leukotrienes and interleukins and all kinds of other mediators, and they seem to work in some patients and not others, and it already seems about as confusing as a sign. Will adding more layers actually complicate things? And what will an expert panel report number 4 actually look like? So the future way of managing asthma is actually to treat each patient individually. Each patient is unique, and out of this recognition is born the appreciation of phenotypes and of novel and different pathways of inflammation. Out of these pathways come novel therapeutics, and perhaps even the reemergence of some older therapies that we've stopped using as much. Immunomodulation will always have a place in asthma because this is an inflammatory disease first and foremost. So despite some of the negative studies that we talked about, there will be some developing immunomodulatory therapies that you will see in the future. Smooth muscle is becoming targeted again, either directly by things like thermoablation or indirectly by medications. And last but not least, comorbid illnesses have always been recognized for centuries to contribute to asthma management, and there's a good reason for that. We shouldn't lose focus on that. So we should always keep a multi-system approach to asthma now and in the future.